So next I would like to introduce Irena Gorski Steiner. She's a doctoral candidate at the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health, where she also earned her master's in public health. She is a hydrogeologist turned environmental health scientist, having earned her BS in geoscience from Penn State University. In 2017, Irena provided testimony to the Maryland General Assembly on the evidence for water quality and health concerns from unconventional natural gas development. And in 2019, she co-wrote a chapter with her advisor, Dr. Brian Schwartz, on the environmental health concerns from unconventional natural gas development for the Oxford Research Encyclopedia. Her dissertation is focused on evaluating the association between unconventional natural gas development and adolescent mental health outcomes, including depression and anxiety. Please welcome Ms. Gorski Steiner.
Hello, thank you so much for that introduction. Let me share my screen. All right, so as Debbie just said, my dissertation is focused on examining the association between unconventional natural gas development and adolescent internalizing disorders, and I'm going to share with you some updates on this work in progress. So I'll start with an overview of what adolescent internalizing disorders are and why I hypothesize they are associated with unconventional natural gas development, which I'll be abbreviating as UNGD. I'll then describe my specific research methods for evaluating that association and the results that I currently have, and then talk about some challenges with that research and my next steps for it. So there's generally a divide in adolescent mental health outcomes between those characterized by internalizing behaviors such as social withdrawal versus those characterized by externalizing behaviors such as acting out. And the mental health outcomes which I hypothesize would most likely be influenced by UNGD activity are this subclass highlighted in green. This is a specific group of internalizing disorders primarily characterized by distress, including major depressive disorder and generalized anxiety disorder. Some depressive symptoms in adolescence include loss of interest and fatigue, and some anxiety symptoms in adolescence include difficulty controlling worrying and muscle tension. Part of the reason I chose to study adolescents is because they have unique characteristics that heighten their susceptibility to environmental exposures, including their high biologic sensitivity due to their bodies still developing and going through puberty, because they often spend more time outdoors than adults, and also because these disorders often first show up in adolescence. So identifying factors associated with depression and anxiety is of high importance because these disorders have a high and increasing prevalence in the United States, with a recent national survey finding that around 25% of adolescents had an anxiety disorder and 10% had a mood disorder. These disorders have high impairment in adolescents, and they also represent a higher percentage of the global disability adjusted life years due to mental disorders. And they rank among the most costly health conditions in the US for covering psychotherapy and pharmacological treatments, including out-of-pocket costs plus spending by insurance. Here I've listed some community and environmental stressors which are part of or related to UNGD activity, a little similar to Dr. Desiel's slide. There's community stress, noise, traffic, loss of green space, environmental degradation, and air pollution. And as you can see with all of these studies, all of them have been previously shown to be risk factors for anxiety and depressive disorders. There's only been one prior study of UNGD and depressive symptoms, but this was only in adults, and this study found a significant association between UNGD activity metrics and mild depressive symptoms in adults. So now moving on to my research methods, I calculated UNGD activity with a method used in many prior studies by the research group that I'm a part of and others. I calculated it for each adolescent, and the metric gets bigger if the adolescent is surrounded by closer wells, more wells, and or larger wells, because the formula takes into account not only the distance between the adolescent's home and each well, but also the total depth of the well and the volume of natural gas produced by them. And this data for these calculations comes from the Pennsylvania Department of Environmental Protection. For my studies, I'm obtaining my health data from electronic health records from Geisinger, an integrated health system in Pennsylvania. Geisinger has over 1.6 million patients total across over 40 counties, and they've had electronic health records since 2001, which provide information on demographics, vitals, diagnoses, medications, health insurance, and more. Across two of my dissertation studies, I'm analyzing complementary measures of internalizing disorders, the first of which is a standardized and validated depressive symptom questionnaire administered at outpatient care visits. It's a screening tool called the PHQ-9, and it contains 9 questions about experiencing depressive symptoms in the past 2 weeks. And patients, these adolescents, fill this out for themselves, and they score each question from 0, stating that they didn't experience these symptoms at all in the past 2 weeks, all the way up to 3, stating that they've experienced these symptoms nearly every day. And then all of these scores are added up, and it gives them a total score of 0 to 27. The other measure of internalizing disorders I'm using from the electronic health records are diagnoses and medication orders recorded at outpatient visits, but due to time, I'll just zoom in to this study based on depressive symptoms. I selected my sample of subjects for this study by starting with the pool of adolescents who were given a depressive symptom survey at an outpatient visit between 2013 and 2016. I excluded any subject who did not complete at least 4 questions, those with inadequate contact with Geisinger prior to their survey, and those who visited a therapist or were prescribed antidepressants in the 60 days prior to the survey, and ended up with around 25,000 adolescents for this study. My interest in this study is to evaluate the association specifically between UNGD activity metric quartiles calculated for the time period of the 30 days prior to their survey and the adolescent's depressive symptom score category. The design for this is a retrospective cohort study, and I'm analyzing it with multinomial logistic regression models with generalized estimating equations. So here's just the initial table getting a feel for who's in this study. It's looking at several relevant covariates by depressive symptom score category. And what I could see from this is that adolescents with higher depressive symptoms are more likely to be female, older, overweight, more likely to be a smoker, more likely to be a resident of an area with lower greenness, and higher community socioeconomic deprivation. So there's many confounders of concern, and I decided to investigate the distribution of some of these variables, not only by depressive symptom score category, but also by UNGD activity quartile to check the comparability of my subjects across the 4 quartiles and the 4 symptom categories, since I had concerns about non-positivity. So here is one example. I have the percent of non-white and Hispanic adolescent subjects within each box. So the N value is the total number of subjects. So for example, this one right here, I think you could see my mouse, shows those who had a no to minimal depressive symptoms, and they were in the lowest quartile of UNGD, and here's the highest quartile, and here's the most severe symptoms. And what I could see is that the percent of non-white and Hispanic subjects decreases from the top right groups of low and UNGD quartile and high symptom category to the bottom left groups of high UNGD quartile and low symptom category. Taking a look at the distribution of another one of these variables, here we can see that there's a trend of increasing greenness measured by NDVI, or normalized difference vegetation index, from the top right to the bottom left of the table. And just one more example, T stands for township, which is a more rural community in Pennsylvania. Borough is somewhere in the middle of rural to urban, and city census tracts are urban areas. And once again, we see a trend across the table, and this one is showing an increasing percent of adolescents living in townships. Another exploratory figure I made to check out my data was this plot of monthly median UNGD activity metrics and monthly mean depressive symptom scores. And what we can see here is that there's a strong seasonal trend in not only depressive symptoms, where you could see there's a little, almost like a smiley face. There's 3 little smiley faces showing that teens are, guess what, happier in the summers, or at least their depressive symptom scores are lower on average. And there's also a seasonal trend in survey administration. There's these bars represent the number of surveys submitted in that month, and there's more surveys submitted in the summer, mostly because I assume adolescents are going for their annual checkup and getting screened for this at that point. And there's also a seasonal trend in UNGD metrics represented by the orange dots. So with all that in mind, this is still work in progress, but I've run an initial model comparing only adolescent subjects in the mild depressive symptom category to adolescent subjects in the no to minimal depressive symptoms category, since we saw that those with the higher symptoms were so different that we didn't think they would be that comparable. So just these 2 lower category symptoms in association with UNGD. And across this table, there's increasing covariate control. So from model 1, we just had sex, age, non-white race, Hispanic ethnicity, and medical assistance, and then added additional covariates control across the table. At this point, though, when you look at the associations with UNGD, every single one crosses 1.0. So I'm seeing only insignificant associations. So this result is not yet definitive, as this is still work in progress, including because of several current ongoing analytical challenges. The first of these being non-positivity. So because teens with high depression symptom scores are different in almost every way from teens with low depression symptom scores, making adjustment for confounding difficult. The second of these is addressing residual confounding, potentially by additional components of seasonality, socioeconomic status, and other factors. And a third is addressing selection bias. There's likely differences in entering the study, differences in people being able to take a depressive symptom survey by key predictor variables, including UNGD quartile, who seeks care in the first place, who, when they go to their appointment, is actually offered a survey, and who will actually agree to take the survey due to differential stigmatization of mental health outcomes and depression, as well as health insurance could also be affecting this. Some of the next steps in this work in progress are evaluating potential spatial and temporal bias. Planning to do this by comparing the distribution of my study sample with another study sample, which found a significant association with UNGD activity metrics. And I also plan to investigate other methods for addressing selection bias and residual confounding, including propensity scores. I'd like to thank many people advising me and supporting me with this research listed here. And if I don't get to your question at the end of this panel, feel free to contact me at this email address right here. Thank you.